For that, and good morning, everybody, and thank you for the introduction. I'm getting a little bit of feedback, but I'm not quite sure. Hang on a second. I just moved the phone there. Right. I'm not quite sure why there's such feedback. Are other people hearing the feedback? Actually, I'm just saying,
yes, we are hearing the feedback. If you turn off, or if you turn down your sound, then hopefully the feedback will go.
Okay, so how's that?
That's a bit better. Yeah, that's a little bit better.
Right. Anyway, I'll move on. Anyway, good morning, ladies and gentlemen. Thank you very much for joining this workshop. The workshop is about the use of linked data in responding to COVID-19 pandemic in Wales. How we're using the data to support policy, services, the response for Wales and the UK in order to make a difference for people. I'm joined by my colleague, Ashley Barry, and a number of us who we're going to help with breakout sessions, but because of the COVID epidemic, the technology doesn't quite allow that. So if I move on to the next slide. So will the one be before? So the agenda basically is about the development of this One Wales approach that we've taken. I'm going to include some exemplars of work that we've created or are underway, funded by the Medical Research Council. And then in the discussion, we can talk about additional opportunities and potential analyses, and then provide some feedback. Next. So largely, this is about the use of data in the sales system. There are also quite a lot of analyses which are underway, carried out either by NHS Wales Informatics Services or Public Health Wales using linked data, but not through the sales system. It's worth pointing out that anybody can apply to use the data through sale, and there are many different projects underway. I'm going to focus particularly on the work that my HDR UK team is doing, and how we're working with the Welsh Government Technical Advisory Group, and that group also feeds into SAGE. At the bottom of this slide, there is a list of organisations and groups who are part of this work, and I just want to pay tribute to them. That all of this work would not have been possible without them. So next slide. One of the things that Health Data Research UK does is it gives every 2 weeks a feed into the Scientific Advisory Group on Epidemics, SAGE, on what data are available across the UK in the different trusted research environments. And there are 4 of those: SAIL for Wales, NHS Digital for England, 1 in Scotland, and 1 in Northern Ireland. I'm pleased to say that with the help of a lot of people, more data are available in Wales, and there are more projects undergoing using Welsh data than anywhere else in the UK. Next slide. So essentially, this is the title of the activities, about how we use de-identified data to look at the impact of COVID-19 on the population. In order to do that, we've created 2 total population linked cohorts of de-identified data, and they're derived from a previous investment into a thing called the Wales Multimorbidity Cohort, which is funded by Health Data Research UK and the Medical Research Council. So we have adopted that to create these two cohorts. For short, we call one C20, there's cohort 20. That includes all the people alive and known to the NHS on the 1st of January 2020, and we're following them up prospectively. And the equivalent cohort from all of those alive in 2016 and followed up until the end of December 2019, which is the counterfactual cohort. I mentioned earlier that that's now supported by a grant from the MRC, and we have supplemented that with additional data collection, which is happening in care homes, schools, in pregnant women, and in teenagers. And I'll say a bit about that as we go along. Next. So this is the title of the MRC grant we have, Controlling COVID through Enhanced Population Surveillance and Intervention, a Platform Approach, or CONCOV for short. And we have 4 main objectives. There is a work package, which is looking at the demographic, socioeconomic, and clinical risk factors for infection, illness, and death. We're also looking at the risks of COVID-19 infection and outcomes in particular occupational groups. There's a large body of work on looking at the population impact of COVID on healthcare utilization across the entire population. And then we're also using this as a platform to enable the evaluation of policies and interventions aiming at controlling the epidemic, whether they are clinical or non-pharmaceutical in nature. Next. As I said, we've built a large team across many different organizations to do that. I've tried to capture pictures or photos of them all, but I've probably got about 2/3 of them. So there probably are many people in this from different organizations that people can recognize. Given the presentation, it takes too long to actually just name all of the people, but they've all made a tremendous impact. Next. So just the basic contents of these 2 electronic cohorts. You can see that they both have about 3.1 or nearly 3.3 million people. The C16 one finishes in December 2019, and the C21 begins in January 2020. And for the purpose of some of the analysis that I'm going to show you, it has finished in either, or the analysis stopped in May, but then others are going. Up until that period of time, some 16,500 people have died in Wales, and you can see the sort of numbers that have died in the other cohort over that 4-year period. And this gives us pretty good power to detect lots of effects on mortality as they develop. Next. So emergency department data gives quite a good insight as to what's happening. And here we're looking at 7-day rolling averages of emergency department attendances in 2020. The dotted red line in the middle is when national lockdown occurred on the 23rd of March. And you can see that before that period, we were running at about 2,500 people attending a day. And that number plummeted about 10 days prior to the lockdown as the population restricted their movements restricted having quite so many injuries, and also attending at the emergency department. I'll move on to the next one. So this is just a slightly different view of the same thing. You can see, compared to the 2015-19 period in this case, the beginning of 2020 was pretty similar. And then we had this huge reduction, which has now started to increase as lockdown has sort of come to an end. I would disregard the terminal decline in some of these graphs. Despite the data being released and meant to be completely completed, we find often there is some delay in coding some cases. So I'd ignore the terminal declines. Next. One of the things that is noticeable also, whilst the numbers of people who attended emergency department fell, actually the proportion of cases with more severe outcomes rose. So this graph basically looks at the proportion of people who were, of those attending an emergency department, who were admitted. And you can see that that proportion has increased during the early phase of the pandemic. Next. Moving now on to what's happening with outpatient attendances. Again, you can see that the early phase of 2020 was very similar to previous years, but then we've sort of had about a reduction of about half in all outpatient attendances. And again, this one now is looking at the number of people treated for cancer, and how that's changed on a monthly basis, comparing the previous 4 years with the current ones. So this is, in this graph, you can see that we were treating more people in the beginning of the year than in the previous years, and that has fallen quite a bit. Graphing the data like this helps us understand that in this case, actually, the 4-year comparison isn't so good, because the numbers being treated have been increasing over that time, and a better comparison is at 2019, but still a sizable drop in treatments. Next. And this time looking at surgical procedures or operations. Very similar in the early phase of the year, but again, a very marked reduction in surgical activity. And again, here we're looking at the numbers who typically attend with heart attacks or strokes. And that shows one of the largest of drops in the early phase. There's considerable concern about this and some of the other ones, as those people will have missed out on treatments which can be life-saving or have a major impact on the likelihood of residual disability. Next. And another area that we're working on is the evaluation of shielding. Trying to answer the question as to whether shielding played a role or not in protecting people from infection and adverse outcomes. So this slide just quite busy. It really just shows the basic data structure and our ability to track people before and after the event in the 131,000 people who were shielding in Wales. At this stage, I wouldn't pay too much notice to the numbers in each of the groups because the evaluation is ongoing. And next. One of the areas that we've done quite a bit of work is on the impact of COVID-19 on the population in care homes. This was based on work that Joe Hollinghurst and colleagues have been doing on care home data linkage. And here we can see the survival curves for people in care homes in the previous 4 years, and the major difference that we've had with COVID-19 in the early phase of 2020. And so that's work that's ongoing. There's a lot of additional data collection going on in relation to care homes, in how we're trying to understand where the infections came from, and in evaluating new policies and interventions to curtail having a second wave of that. Next. One of the other data sets which is used quite widely is the Zoe Symptom Tracker app. There are some 4 million people in the UK who are using this to record their symptoms over on a daily basis over a quite long period of time. It's one of the most useful data sources in that it tells us something about symptoms and the likelihood that those symptoms identify COVID or will lead to infection that's picked up in hospital. The group led by Richard Fry have been mapping these, and you can see on the slide there examples of the interactive mapping which shows hotspots. And those interactive maps are fed to the Welsh Government Technical Advisory Group and to ministers quite regularly. Next. A further area of work is on the evaluation of COVID-19 on healthcare workers. To do this, we had anonymized and linked some 105,000 records from the electronic staff record system, which 98% were linkable. We've divided those with the help of NHS colleagues into groups that are patient-facing, non-patient facing, and in some cases undetermined. Largely groups that normally would be patient-facing, but largely have managerial positions. And if I move on to the next slide. So here you can see the epidemic curves of infection on the left-hand side. So the left-hand side are the numbers of patient-facing workers and non-patient-facing workers who tested positive in the early wave. You can see that most of the undetermined group really fit into non-patient-facing roles, given the changes. So on the left-hand side is the antigen and genomic tests in relation to active infection. And on the right-hand side, we started to use serology tests, which marks previous infection, and that's over a later time period. If I move on to the next slide. Probably the easiest way to look at this is the cumulative likelihood of staff members testing positive. So the first graph here are the tests for active infection, the so-called the pillar 1 and pillar 2 tests. And you can see that that is about 6 or 6.5% at the end for healthcare workers, and about 2% for those non-patient facing roles. And if I move on to the third one, which combines the data on active infection with past infection. Those gaps remain, but the proportion of patient-facing roles which have evidence of active infection are about 10%, and close to 5% in the non-patient-facing roles. It's worth pointing out at this stage that not everybody has been tested, so these will be an underestimate, but they give some indication of what has been happening over time. And next. So just to point out that we're also doing quite a bit of work on different population segments, and this is work which is in progress or planned. So on the occupational groups, we are going to start analysis in relation to social care workers, the care home staff, as well as the residents, expand the work we've been doing by healthcare workers by more defined rules. We also have a system to anonymize and link data on all pupils in schools and school staff. We'll be answering a host of questions such as how much does transmission occur in school settings, which is a hotly debated topic. We're also collecting additional data in schools on non-pharmaceutical interventions and behaviours for both national and international case control studies. Ashley is leading a lot of work on ethnicity. A lot of the routine NHS data are poorly coded with ethnicity data. We will be bringing in ethnicity data on the healthcare workers in October, and we've also had permission and have just linked the census data from 2011. And that will allow us to improve and validate the NHS coded data. I'll move on. I'm coming to an end on this one, just to say a lot of the work that we're doing is not just UK-wide, but we're involved in collaborations across the UK, particularly in the area of cardiac disease with the British Heart Foundation, HDR UK Centre, cancer in the DataCan collaboration, and that's work we're doing at Public Health Wales and the Wales Cancer Research Centre. There's a respiratory group with a paper which is just being submitted on the impact of asthma, COVID-19 on asthma in Scotland and Wales. We've been working with the Nerve Tag research group. They have a commissioned piece of work trying to refine risk prediction tools using Q research data. There's a paper on that which has just been accepted by the BMJ and should be out soon. And we've been involved in the validation of that in Wales, Scotland, and Northern Ireland. We also provide follow-up data to consented studies. Many of you will have heard about the recovery trial. That's the trial run by colleagues in Oxford, recruiting people right across the UK. The one that's shown that dexamethasone works. There is another group called ISARIC 4C, which is about clinical characterization, and they're following up at this stage 82,000 people who've been hospitalized with COVID across the UK. And then genomic, which is about the genetics of recovery. I'd like to point out also that Wales has been successful, a bid led by Public Health Wales, to create the Network Data Lab Wales initiative from the Health Foundation. And so there's a lot of parallel work going on there. So we go on to the next slide. So at this stage, I'm going to pass over to Ashley in relation to the question and answer session.
Brilliant. Thanks, Ronan. Just to say, in terms of the echo, I think we've worked it out. It's probably because you've got two Crowdcast windows open at the same time. So if you try and close one now while we're just setting this up, that should remove any echo that's left over. Okay, brilliant. So thanks for that, Ronan. So just to say, as Ronan mentioned earlier, our original hope was that we were going to have a bit of a breakout session here and do some town hall type scenarios. But unfortunately, due to COVID and not being able to get together physically and some issues with the software, we're going to turn this into a Q&A session now. So as mentioned by Kate earlier, if you would like to send any questions you would like to put to Ronan or the team, either via the chat box or over the Q&A, I will go through those and read them out to Ronan, who can answer them on behalf of the group that is here today. We're really keen to get everybody's feedback and information. The reason that we wanted to run this workshop today was not so much for our team to understand further work that we could do, but more to understand what work was possible across Wales, and so that we could feed back this information and intelligence to Health and Care Research Wales, as well as the Technical Advisory Group and others around Wales, to really try and identify potential gaps or potential information that could really help drive further initiatives moving forward. In aid of this, we've kind of got a few key areas or key questions that we're aware of that we would like some further input on. So whether you want to draw upon these or answer other ones is down to you. But the three key question areas we were really interested in finding out of people today were: what do you think are the main challenges we face in Wales and across the UK, either directly or indirectly from COVID-19? What are the key priority areas that you think health data science and big data potentially should focus on to support any challenges or potential opportunities? And obviously data is very important to what we do and what could be possible across Wales. And we're in a very good position in Wales and across the UK with this. So what data or organizations do you think we should be involving in our efforts and other people's efforts? And whether they are already involved or whether the data is already available, feel free to pose those questions or points. So hopefully Ronan's had a chance to sort out his Crowdcast and we've got rid of the echo. So I'm just going to start now with regards to the first question that we've had. So from Reshma, thank you for the presentation. Some really interesting and impactful data. I wondered whether SAIL is linking in with the daily SITREP data from the NHS organisations, or is that separate based on a different need? So Ronan, did you want to answer that one?
And can I apologise for failing to see I had that thing open twice and caused the feedback. We do get reports of SITREP data, but the difference in SAIL and the SITREP data is that in SAIL, it's longitudinally linked individual data, although be identified. But SITREP data effectively just counts. So like how many people are in hospital, how many people are intensive care beds, how full are the beds. It's useful contextual data, but it doesn't sort of quite help us answer the questions about the impact on individuals.
Okay, brilliant. Thank you, Ronan. And just to add to that, from what Ronan said with regards to the daily SITREP data, it has been useful for critical care colleagues in particular, as the daily SITREP data, if you're not familiar with it, contains things like the number of beds, the number of ventilators, but it's aggregate level information rather than patient level information. So as Ronan said, it's been helpful to aid in the understanding of the direct and indirect effects of COVID on services. So it's been helpful to acquire that data. So the second question then, Ronan. So from one of the slides you presented, admissions with MI fell at the start of lockdown, but did mortality rise? And that's from John Williams.
So yes, mortality rose in terms of excess mortality quite substantially, and there's an increase in the number of people dying, obviously, from COVID. What we can't say, however, is did the mortality rise in those people who didn't attend? Because of that, we're not really sure why they didn't attend, but so we can follow it up that way. But on excess mortality, which is far higher than the COVID-coded mortality, the answer is yes.
Okay, thank you, Ronan. So another question that's come in. So how do you think COVID-19 has changed research in general across the UK or the world? And are there any positives that could be potentially drawn from this unexpected impact of the pandemic?
Yes, there are not many silver linings to the COVID pandemic, which has had a massive impact on the population and on individuals. But it has helped with research in a number of ways. People are far more willing to collaborate on a national initiative to respond to the pandemic. So that has been enormously helpful. I've not seen as much collaboration previously. That has also helped free up data sets that were previously difficult to access, as everybody wants to play a part in understanding how the pandemic is evolving and contributing to interventions that can reduce the impact on the population. So those things have been very good. Some data sets have been made available through emergency legislation like the COVID COPI regulations. The utility of that data, hopefully we will see a situation as when COVID goes, that the data are still available to the research community to answer important questions on clinical and population health issues.
So just as a quick follow-up to that, Ronan, and obviously for people who aren't aware, the COPI regulations essentially allowed organizations to still in a secure and well-governed and processed way share data with each other, but allowed it to be expedited in a way that previously prior to COVID wouldn't have been possible. So do you think there's any learning that we can potentially gain from those data that would allow us to potentially enhance opportunities moving forward and therefore gain access to them in the future? And are there any data sources that you're aware of that we've accessed that potentially we haven't had access to before that we'd like to keep hold of after COVID?
Right. So quite a few questions there. Yes. So if I go to data that have been very, very helpful, obviously the testing data and the serology data on people. One of the things that it's not just the data that are being made available, but the frequency of it or the cadence of it that has improved. In the past, many of the data sets we got quarterly or annually in arrears. Most of the routine ones are now monthly, and some of the ones, such as the testing results, we're getting daily. And so being able to respond to questions about very frequent data is helpful, and we hope that those data that are being made available frequently, we can keep that up as time goes by. Some data sets which we previously hadn't available in Wales, such as the dispensing data set, has been made available for COVID, and that's been very helpful. That's something that is a data set that's widely used in England and Scotland. It's good to see that we're starting to get use of that in Wales. And then other data such as the census data, because of the poorly coded ethnicity fields in the routine data, linking securely to the census data will help enormously with that.
Okay, brilliant. Thanks, Ronan. So thanks for all the questions coming in. Keep them coming. So the next question then, Ronan. So Ronan, thank you for the very informative presentation. Can you expand on the data that you expect to get from ONS in the next month and whether this will be available for researchers to access? And that's from Pauline Ashfield-Watt.
I'm just trying to think on my feet as which data we're expecting from ONS in the next month.
So it's not in the comment, but I could probably expand on behalf of Pauline. So obviously we now receive greater cadence of mortality data, but the new data sources we get are the census and the ONS COVID surveillance infection survey. So those are the two new ONS sources, I think, that Pauline's referring to.
Right. So the census data will be fantastic, useful in a number of areas. First, as I mentioned about ethnicity, but secondly, on socioeconomic position. Everybody's doing lots of research on inequalities in health and trying to understand them. Most of that is based on categorizing people ecologically by where they lived into lower super output areas and using the index of multiple deprivation to group them into fifths. And that helps enormously, but isn't granular enough. And there are a lot of data on housing tenure, on education and jobs in the census, which will help with that. The second part then that I would look at then is about the survey data. So the NewONS survey is now looking, I think, up to 200,000 people across Wales. Moving that serology, the Wales samples into the Sale environment will be helpful in feeding in data from groups that we yet don't fully have data on or understand. So NewONS is a random sample of the population, and there are very few other data sources which are like that. One issue about it, though, is whether the sample size will be enough in Wales for Wales-specific analysis, or whether they're still best used on a UK basis.
Brilliant. Thanks, Ronan. And just to add some further details, the census, other people have now started applying for it in Sale. You do have to request a few additional requirements on top of Sale, which NewONS require, but anybody is able to access the census now via the Sale databank if you so wish, and that would be linked to other data or just on its own. Okay, so moving down to the next question. So we hear about the impact of lockdown on mental health. Are there any plans to look at data sets that might inform the level of this and the need for more mental health care and support?
Yes, on the, I wasn't able to cover everything on the presentation, but there is a mental health group led by Professor Anne John, who are looking at the impact of COVID on services for people with mental health and the health of the general community, both in Wales and across the UK. So quite a lot of work going on there, and obviously quite a lot of growing evidence of negative impacts on people's mental health due to COVID at different age groups. I'd also like to point out some of the work that Sinead Brophy is doing in relation to schools and teenagers, and Sinead is part of the CONCOVE bid, but also linked into the National Centre for Population Health and Wellbeing Research, which is funded by Health and Care Research Wales, have a school health initiative, and they are collecting a lot of additional data through surveys on pupils in schools, teachers in school, pregnant women, and on a general teenage population. So a lot going on there.
Brilliant. Thanks, Ronan. So the next question. So in our emergency department, the drop in green attendances helped us cope with the increase in red attendances. Now we're seeing similar number of green attendances, which is a worry with the threat of a second peak of COVID and the normal winter pressures that face emergency departments. Have you identified any potentially sustainable changes to working practices, for example, in primary care, or messaging to patients that might help reduce pressures this winter?
Yeah, I know, a very interesting and practical question. I'm involved in various committees, but I have yet to see people come up with interventions that would make the changes as desired. I think it's an area of research that's probably insufficiently invested in, and we need to have more of that.
Brilliant, thanks. And just to add to that, as part of the One Wales approach that Rona mentioned earlier in the collaboration, NHS Wales, the NHS delivery unit, and some of the other operational sectors, including primary and secondary care, are all working together on this. So if you are interested in some of those items, then make sure you flag them within the NHS if you are working within the NHS, so that they can get prioritized in terms of the national priorities to look at. And as Rona mentioned, there's lots going on. So moving on to the next question then. So how do you feel the communication of COVID science has been handled in Wales?
Right. tricky to answer that question because the communication of COVID science is really being on a UK-wide basis. There are many different commentators from different universities and different professional organizations, some of them members of SAGE, some of them members of independent SAGE and other groups. And I think it's very difficult then when you've got freedom of speech and you have lots of different groups with different viewpoints presenting those views, to have that organized in any meaningful way. So I'm not sure there's anybody who's really trying to organize all the scientific communication.
Okay, thanks. And then building on that question, so any ideas about how we can make the research of results of current COVID research more accessible to the public?
Yes, one of the things that we've been doing in our group is that we have recruited a number of members of the public to sit on our steering committee and advise us on what we're doing. And when I finish this presentation later today, I have a presentation to the consumer panel about what we're actually showing, and we'll be working with them about how you actually turn these into public-facing outputs that help with public understanding of science. But it's a very important area. It's a very technical area, and undoubtedly there are a lot of people who are a bit confused and befuddled by the terminology that's used. But certainly investing more in public engagement is an important aspect.
Brilliant, thanks. So I'm going to carry on reading. We've got a couple more questions, but just to prompt for some more. So in terms of our second question we've got on the screen, what are the key priorities that you think we should be focusing on, or the challenges we should be focused on? If anybody's got any questions or suggestions, then feel free to send them over the Q&A or the chat. So moving forward to the next question then, Ronan. So how did your team manage with such an enormous volume of work and demands on their time?
Well, I'm really fortunate to be part of a fantastic team of people, a large group of people who put enormous amounts of effort into what they're doing. A lot of people were on furlough, but actually the team took hardly any holidays, and still many of them haven't done so in order to be able to play their part in this national emergency. They're superb, and we've worked really well with groups of people in different organisations like Gareth John's group and NWIS and others in Public Health Wales, and everybody sort of came together in this sort of national crisis to help with understanding. But we're fortunate to have such a group, but I think when you look at all of the questions that need to be answered, it's an area that needs to be invested in a lot more across the UK and Wales, and also particularly within the NHS. For many years, I've pushed for the NHS to link all its own data, every organisation to have its own analysts who can answer these quite complex questions. But that's an area that's massively under-resourced.
Brilliant, thanks. So moving on to the next question. So with regards to the main challenges, one of these is to predict or estimate the impact of reduced clinician-patient contact and reduce routine reviews, as well as patients coming forward less with non-COVID illness. Which patient groups might be at the highest risk in the future, do you think?
Of not attending. One of the things that obviously in the crisis that COVID has come up, there are all sorts of changes in health services that have been instigated. It would be fantastic to see many of those changes, also to have alongside them a really detailed evaluation plan about what difference they make or don't make to different groups. I'm not aware that a lot of them have built-in evaluations. That's something that should be done. So without that, it's you sort of guessing what might happen. I think there is particular concern about patients who have not been presented or haven't been able to be seen with symptoms suggestive that they may have cancer. And there's obviously the concern that I mentioned earlier about patients who may have chest pain or be suffering from strokes, but who aren't presenting. And I think some of our messaging about staying away from the NHS has been a bit simplistic, because there are groups that when they have urgent problems, that we really need to ensure that they get seen. So I'm not quite sure I've got a specific answer to that question about who would be most at risk.
No problem. So moving on to the next question then, but feel free to come back with a response if you'd like Ronan to answer in more detail with specifics. So on to the next question then. So how do you think we ensure that those making decisions in Welsh Government, in policy or NHS Wales, understand the complexity and the implications of the data that are used and presented?
So I'm not a member of Welsh Government or the civil service, but I'm quite pleased to be a member of the Technical Advisory Group, which gives an opportunity to discuss the complexities of the data, what it shows and doesn't show. And there's a large number of different experts across Wales who's contributing to that. So I think that's helping feed in to understanding. It's important to point out that a technical group like that doesn't make policy. What we're attempting to do is clarify the science around all of this, and hopefully that will ensure better policy decisions.
Brilliant. So feel free to send your questions in. We've got about another 8 or so minutes left. So just one from me, Ronan. So with regards to obviously COVID research, there's so many priority areas that could be answers, and there's so many things that could be researched. If somebody was interested in getting involved in research or doing their own research, what would your advice be to them in terms of how to best go about this in the future, in terms of working with others or making a start on COVID research based on what we've learned thus far?
Yes. I mean, I think that there are lots of people with lots of different questions. I think the first thing is to try to understand what's out there, first of all, and to see whether that question has been answered or not. That can be quite challenging. So, for instance, the research councils have funded quite a lot of research, but they've been so busy funding them, they still haven't quite made the announcements of all the things they've funded. So there are quite a lot of initiatives which are going on that nobody really knows about other than those involved. One of the helpful things, I think, in this pandemic is the change in publishing outputs. So a lot of groups have been publishing preprints of research on things like medRxiv before those papers went to main journals and the delayed response to them. So I think searching on those sort of archives for preprints gives a better indication of what's been happening. And then I think it's a matter of actually just talking to research groups about whether that question has been answered or not, and if anybody is interested in doing it. There are lots of different funding opportunities at the moment for groups to be able to bid to do work. And I think particularly now that the sort of very rapid phase of research around transmission of COVID has come to an end, there's, groups such as NIHR and the MRC and that, who are really looking at funding studies on the longer term impacts of people who've been affected and the general population. So I'd also have a look at those groups who are funding research in this area.
Brilliant, thanks. So questions just come in. So do you think this pandemic will pave the way for more and potentially easier collaborations in the future?
Yeah, I certainly hope so. I mean, I've been struck by the fact that lots of groups that were initially spread around the country doing their own things have come together. There are a lot of UK-wide groups and initiatives. people have engaged in team science to a greater extent than previously. Obviously, that is now also spreading in the international arena. So hopefully this is, if you like, not just a temporary blip, but a major change in the way collaborative science is undertaken in the future.
Brilliant. Another one from me then. So with the recent announcements of local lockdowns coming into effect more in Wales and across the UK, and obviously the recent news this week with regards to students in particular, from a data point of view and from a data science point of view, how do you think data science could try and support investigating some of those and supporting better local lockdowns in the future? Do you think that's possible?
So, well, the decisions on local lockdowns are largely political, based upon a threshold of infection. Once it's crossed, it tends to come in or not. I think as the pandemic evolves, people will get a bit more astute into what drives some of these, about where exactly transmission is occurring, what interventions, particularly non-pharmaceutical interventions, are working, and then how they're evaluated. So I think that quite a lot of evaluation will help inform that. I don't know an enormous amount at this stage about the evaluation of infections in universities. Actually, that's an area where I think there is very little data or data available on what proportions of the student population are infected, and in higher education, and how that has changed over time. But I think if you look at all the sciences that's being undertaken across the UK, the findings of those evaluations will help with the policy decisions down the line.
Okay, and then the last one, unless we get any more questions come in. So obviously, our main focus as a group is data science and big data, but we obviously work with trials a lot. So what do you think the major changes have been with regards to trials when it comes to COVID-19? And can you see any benefits or long-term changes that they've learned from in terms of the pandemic as well?
Yes, I mean, I think I'd used a recovery trial as an exemplar. It's superb. The speed at which it was set up, the speed at which it recruited patients right across the UK has been absolutely amazing. And it's now designed with routine data follow-up on all participants across the UK to make it one of the most efficient trial setups that we've ever seen. So you do hope that in future, all trials are as easy to set up and recruit across the UK, whether dealing with COVID or not, and all have automatic routine data built into their follow-up.
Brilliant. Thanks, Ronan. So I think that draws a close on the questions. So thank you, Ronan, for answering, and thank you, everybody, for submitting your questions. Just to say, the session has been recorded today, so we will take the questions and the feedback and we'll pass those back to Health and Care Research Wales and to the Technical Advisory Group, as we mentioned. So it's just to say then from myself to close the session, we'd like to thank everybody for their attendance and their input today. And Ronan, I'll just hand over to you to close, and then I'll pop the last slide up with contact details.
Yeah, well, thank you very much, Ashley, and thank you all very much for listening in. As I say, I apologise about the feedback. I hadn't spotted I had two windows open. And it's been really helpful, and please get in contact if there's anything you would like to discuss in the future. So thank you then.
Brilliant. And just to say, obviously, please get in contact with Health and Care Research Wales, who've organised the conference, and thanks to them for putting this on and allowing us to do a workshop session. It's really appreciated. I popped my email address and my Twitter account there if anybody wants to contact me via that, or by all means get in touch with the Sale Data Bank team or anybody else. And once again, really just to thank and acknowledge everybody that's been involved in the One Wales partnership. We would not have been able to do what we have done in COVID without all of those different organisations across the NHS, government, academia, the public, all getting involved and supporting us to get to where we are. And of course, SAIL wouldn't be what it is without data providers and the public providing their data anonymously for research. So just once again, thank you very much.